You can see the screen with the underlining and all that, right?
Yes, sir.
Okay. Good morning, friends. Wishing you all very happy, I can say, an Indian New Year. It's Vaishakhi for somebody, it's Vishu for somebody, it's Tamil Puthandu here. So wishing you all a new year, and let this new year bring you hope, make you achieve all your dreams and get into the course of your choice and set you on your career path. So welcome all of you to this, the last presentation that is due in our session for the 128 session. So today we are going to talk about the tumors of the skin. Okay, so skin lesions. Now there are a few points that we need to know with regard to the anatomy and with the management of skin lesions. I'll be highlighting only a few of the benign skin lesions because they are not generally asked. Only the questions that I've asked, I'll be highlighting. The rest of it is there in your notes. You can go through that. And mainly I'll be talking about melanomas and squamous cell and basal cell carcinomas. The rest of the benign lesions, you have the notes, which is a complete coverage of both Bailey and Sebastian and a bit of Schwartz as well thrown in. So that should be good enough to kind of make you understand what is there. Right. So we all know that there are 5 layers in the epidermis of the skin: the stratum corneum, the lucidum, the stratum spinosum, the stratum germinativum, and the stratum granulosum, and then the stratum basale. So which skin layer do skin tumors originate from? If you look at it, stratum corneum, each of these layers, I'll be providing what is the important. Stratum corneum provides protection against UV rays. Now, only 5% is due to epidermis, 95% is the dermis. Now, the thickness of the epidermis is going to vary. It is thickest in palms and soles, as we know, where it is around 1 millimeter thick. In all other areas, it's around 100 microns thick. For example, in other areas, it will be variable. The thinnest will be in the eyelids and the thickest will be in the palms and soles. Now, what are the 5 layers? The stratum corneum, the stratum lucidum, granulosum, spinosum, and then the stratum basale. So these are the layers. The stratum corneum or the keratinase layer, the keratin layer that protects against UV rays. Then you have the lucidum, which is a clear cell layer. Then you have the stratum granulosum, stratum spinosum. This is the layer where you actually have the keratinocytes and the production of keratin that takes place. It also contains the antigen presenting cells, which are known as the Langhans cells. So they present the antigens to the T cells. So these are the antigen presenting T cells, and they will have the big granules. The importance is these Langhans cells are kind of destroyed by our UVB radiation, and that is the reason that our skin cells become sensitive to the various kind of cancers. Now, stratum basale, the cell layer from which everything originates, is usually from the stratum basale, stratum germinativum, the basal cell layer, the Malpighian cell layer. The other name for this is also known as the Malpighian cell layer. Now, these are all the various names of these, layers. And the stratum basale is the most important one. Here, it contains the melanocytes, which are derived from the neural crystals. It contains the melanocytes, which are derived from the neural crystals. So almost all tumors originate in the stratum germinativum or the stratum basale. Now, other than melanocytes, it also contains the Merkel cells, which are light touch mechanoreceptors. Now, there is another group of cells which has been recently mentioned, known as the Toker cells, which are found in the epidermis, which is the possible origin of your Paget's disease. The Toker cells are the possible origin of your Paget's disease. And this is something called as angiosome. Now, there are some areas where we find loss of blood supply leads to kind of necrosis of the skin, and there are other areas where it doesn't lead to. This is because there are some communication in adjacent segments. Now, these areas which are kind of like supplied by adjacent segments. These are known as your angiosomes, which have their own end arteries and veins, and they have a communication between them, which is known as the choke vessels. Now, these choke vessels, when they are getting affected, is when you will go for ischemia. So, dermis, generally there are various types of collagen. In this, the type 3 collagen is commonly found. Type 1 to type 3. Type 1 is the one which is commonly found, and type 3 is the one which is least commonly found. If you remember, in breast, for example, in the basement membrane, we'll talk about the type 4 collagen. Okay, you will have the type 4 collagen, which will be commonly found there. So common, but the most common variety overall is going to be your type 1 collagen, which is responsible for the resistance of the skin. The color again is due to the distribution of melanosomes. It is not the number of melanocytes. Okay, the type of melanin and also the higher melanosome creation that will happen in the melanocytes is responsible. It's not the actual number of melanocytes that is responsible for the color. and eccrine sweat glands present everywhere except at the lips. We know that. That is why especially common in the palms and soles. So these are the areas that will be where it is found in high numbers. So that is the reason why we have sweaty palms at the time whenever we are stressed. So sweaty palms are due to the eccrine sweat glands, and of course the apocrine glands are found in various areas that are important to sexual function like axilla, groin, all these areas which will stimulate the pheromone secretion that is due to your apocrine secretion. Now these are under the sympathetic stimulation, adrenergic, whereas the ecrines are under the cholinergic stimulation. So these are some points in anatomy and physiology. Now this was a question which was actually asked yesterday in one of the groups, as which is the one which is going to be autosomal recessive. Beautifully worded question. I love the way the question was framed. So if you look at this, you have basically which of the following is autosomal recessive? All the following are autosomal dominant. Most conditions will be autosomal dominant. Here the answer is of course your xeroderma pigmentosa. Now the pathways of repair are going to be different. That is why sometimes they may word it differently. For example, NF1 is in chromosome 17. Okay, NF1 will be in chromosome 17, neurofibromatosis, where you have the typical the coast of California pattern and the main pattern, as we call it. One is smooth, the other one is going to be much lobulated. So that kind of thing is going to be there. So these are the cafe au lait spots. Usually more than 5 cafe au lait spots, more than 5 centimeters in size are going to be significant. Then you also have these kind of leash nodules which are present, and it is an autosomal dominant. 30% of cases it can be sporadic as well, non-inherited sporadic type as well. Then you have the Gorlin syndrome, which is again autosomal dominant, but here it is associated with tumor suppressor gene 9q. Remember, the NF1 gene, neurofibromin gene, is also a tumor suppressor gene. The same way, Gorlin syndrome associated with the patch protein. Now, this particular locus 9q is associated with a lot of skin tumors. So, Gorlin syndrome, where classically you have multiple BCCs which will be present. Along with that, you will have the palmar pits, bifid ribs, hyperteliorism, molar cysts. So these may be some questions. Gorlin's is a favorite, syndrome as far as examiners are concerned. That is also an autosomal dominant condition. Here you have the patch protein 9q. Then you have multiple BCCs. Then you have palmar pits and your molar cysts. So these may be given as a syndrome complex. So that is going to be there. Then xeroderma pigmentosa is again associated with the same locus, but this one is an autosomal recessive inheritance that you will have. Here you are prone to multiple skin cancers, basically squamous cell cancers, basal cell carcinomas, your melanomas, everything can happen in your xeroderma pigmentosa. And many of them will have a mortality by around 20 years of age. At a very young age, they will die of multiple skin cancers that happen. So that is the only one which will be autosomal recessive. Then you have your Gardner syndrome. This Gardner syndrome is going to be your FAP variant of 5q. So this one is autosomal dominant as we know, and it's associated with your epidermoid cyst. So classically associated with the epidermoid cyst in the FAP, that is known as your Gardner syndrome. There is one variant called as Ferguson-Smith syndrome, which is associated with self-healing squamous cell carcinoma, which is again autosomal dominant. So that gives you the answer. The only recessive mode of inheritance is going to be the xeroderma pigmentosa gene, which is going to be the patch gene, which is involved here. Now, Stevens-Johnson syndrome, I am not going to dwell on this too much. These are some things which are given in Schwartz. So just remember, SJS is something where the mucous membrane involvement is commonly seen. In 90% of cases, we have SJS involvement. Now, there is a difference between Stevens-Johnson's and toxic epidermal necrosis. Both of them are basically the spectra of the same thing. So when extensive SJS is present, when more than 30% of the body surface area is involved, that is known as TEN or toxic epidermal necrolysis. Stevens-Johnson, on the other hand, is going to be less than 10% of the body surface area. So the involvement is less, it is called as Stevens-Johnson syndrome. When it is more, it is called as TEN. This may be a clinical picture that may be given where you can see that there is extensive bullae blistering and all that which will be happen. And these blisters, suppose you have your hand, you apply pressure like this, at right angles to this is the angle of where the blisters are going to be present. If you apply lateral pressure like this, so that will be known as the positive Nikolsky sign. So basically you press on it, the skin will peel off and come. That is known as the positive Nikolsky sign. So epidermis separation from the dermis will happen. So this is known as your positive Nikolsky sign, and usually happen within 8 weeks of initiation of a new drug, usually drug use. So this is the one which will be happening here. And granulysin is supposed to be the protein which is implicated. Now, going on to traumatic injuries, again, not a very common topic, but here they do talk about the pressure source. Okay, they talk about the pressure source. Now, question is, which is the most common site of pressure source? That is something which is commonly asked. There are two answers. One is sacrum, which is mentioned. The other one is your ischial tuberosity. I think it is mentioned as ischial tuberosity as far as Bailey or Sebastian is concerned. So I will go with that as the option. Though we commonly see pressure source in sacrum. So the answer commonly will be the ischial tuberosity. That is where we commonly get the pressure source, the most common site. So in this, the stage 1 is the non-blanching erythema. Now, what stage is this? This is, of course, a stage 4 injury. You can see its full thickness and you can see the base necrosis, which is going to be present. Now, the same full thickness extending, but not including the fascia, without any necrosis at the base, that is known as your stage 3. And on the other hand, when you have stage 1, it is going to be just non-blanching erythema. Non-blanching, as in like when you press on it, it will kind of like become white, and then when you release it, it will become red. That is known as blanching erythema. Non-blanching is even if you press it, the erythema will persist. Stage 2 is going to be a partial thickness with formation of blisters usually. So initial stage is erythema, second stage is blister formation, third stage is going to be full thickness, but without the base getting involved. And fourth one is where the bone, muscle, base, whatever tendon is at the base, that is going to get involved. Now in this, the stage 4 definitely needs debridement and placement of flaps. On the other hand, stage 3 can be managed by only back dressings. Currently, most of the pressure source, instead of doing a full thickness surgery and resection and kind of like flaps up front, you just do a minimal debridement to make sure that all the necrotic tissue is taken away, and over that you will put a back dressing, and usually it will heal beautifully. It's just remarkable how it can heal. So the most common site is going to be the ischial tuberosity. That is the most common site. And then you have the greater trochanter. Third, the sacrum is mentioned. This is as far as Schwartz and even Sebastian also mentioned the same thing. Fournier's gangrene is a favorite with the examiners. So here the most common organism, unlike what we think as Bacteroides or Proteus, it is the group A beta hemolytic streptococci. So it is a polymicrobial infection. One is going to be your group A beta hemolytic streptococcus. The other one can be Staphylococcus, E. coli, Clostridia, Pseudomonas, Proteus. So many other species can be present. Now, Schwartz will give you a separate classification. So in this, the type C is related to your, type 3 is related to your salt washer exposure. V. vulnificus. Okay, V. vulnificus is the organism which is grown here. So type 3 is due to your salt washer exposure. And type 2 is the one which we commonly see associated with the group A beta hemolytic streptococcus. That is the most common type overall. And type 1 is due to Clostridia. Type 1 is due to Clostridia, and basically your tetanus based or gas gangrene and that kind of thing may happen. Now, always any kind of necrotizing fasciitis is going to be a surgical emergency. Immediate debridement to the viable bleeding edges. It is not just for your exam guys. This is important even for practice. So whenever you do any kind of debridement in most of the septic conditions, remember, go back to your viable area. There is only one exception to this. That is the case of diabetes, where you try to remove as little as possible, because improvement in blood supply may lead to an improvement in the healing at the edges, which look initially non-viable. But in general, all areas just go and cut off till the viable bleeding edges are received. Then there will be edema beyond the erythema, woody hard texture. So these are some of the features that will be present here. And there's a lab risk indicator for necrotizing fasciitis, called as the LRINEC criteria. Various factors are used in that. May not be significant. I will just put it up here for given in the book, and that is why I just put it up here. Purpura fulminans. Now remember, skin lesions are something that can come easily as image-based questions. A lot of IBQs will come, and that is why the entire presentation will have a lot of pictures, mostly from Bailey, also from Sebastian and Schwartz. Now this is characteristically your purpura fulminans. Typically happens in children as a result of Neisseria meningococci, Neisseria meningitis, or due to the varicella infection. Commonly due to Neisseria meningitis, acute form is the most common one, and children less than 7 years are affected, usually with an antecedent upper respiratory infection associated with the protein C or S deficiency. And vascular thrombosis, basically the principle, you can see that there is patchy thrombosis of the skin, infarction, and rapid skin necrosis. All these three are commonly happen. Now, cylindroma or turban tumor used to be a famous question with the examiners. Nowadays, I don't see it so commonly. It is basically a eccrine spironoma. It is a turban tumor. Common site is the scalp. Management is, of course, not radiation. It is by surgery. The management is of course done by surgery. So if you look at the other radiations, which are other conditions that can be present, one is your adenoma sebaceum or Boonville's disease. Now this refers to the facial angiomas. Now there is another picture, and also rhinophyma. I think these are all pictures that are present later. I'll come to that. Now generalized symptoms, this is one short MCQ that can come. Hyperhidrosis, the treatment is going to be by Botox injection, or you can do a transthoracic sympathectomy in case it is not settling down by the conservative methods, hyperhidrosis of the palms. So that is something that can be asked. And lipoatrophy and dystrophy is associated with HIV, with insulin, with protease inhibitors as drugs in HIV, and transplant recipients. That may be a question that may be coming in your examinations as the exception to lipodystrophy or astrophy. And hydradenitis suppurativa, the causative organism is Propionibacterium acnes, happens in the areas of apocrine sweat glands, most common in females and in the third decade. So Propionibacterium is supposed to be one of the agents. The other name may be asked, which is known as your acne inversa. Now there is a early stage. So the early stages, initially you will have multiple abscesses, then you have the sinus or the scar formation, and then you have your coalescing sinus and abscess formation that will happen. So these are the stages of hydradenitis suppurativa. Initially it is just multiple sinuses or multiple abscess initially. Then you have the multiple sinuses, and then finally all of them will come together to form a sieve-like appearance, the cribriform pattern that will be seen in your hydradenitis suppurativa, the carbonization, and then you will have the formation of multiple sieve-like appearances which you get in your hydradenitis suppurativa. So again, going for the common skin lesions, this is your impetigo, classically due to streptococcal or staph infection. The honey-colored tressa, classical, and this one is the diffuse erysipelas and cellulitis. Now, what is the difference between erysipelas? Erysipelas is generally more localized and more sharply defined, confined to the superficial dermis. And cellulitis, on the other hand, is going to be deep-seated, deep dermal infection, and it is more widespread. The edge of the lesions in both is a little difficult. It will be more of a diffuse edge that you will find, but especially so in terms of cellulitis. And this is due to infection of the dermis and the lymphatics that are involved in the subcutaneous tissue. Cellulitis will be usually more widespread. Management commonly is antibiotics unless it turns into an abscess, when you may need to go for drainage and such stuff like that. What is this lesion? This is your classical pyoderma gangrenosum associated with your inflammatory bowel disease. If you look closely, you can see that the edges are appearing violet, violaceous edges as we call it, the purple or violaceous undermining of the edges. Classically, you can see that the edges are pulling inside. If you remember your edges, you will have your, going by this is actually the edge. This part of it is the edge of the lesion. Whenever you have any place where you're talking about an edge, you're talking about this part, which is going to be the edge. Now, if you look at the edges, it can be kind of like proliferating or inverted edges. This is going to be the inverted edges that you will get. Okay, the classical inverted edges that you will get overgoing it widely, that is known as, that will be commonly seen in the squamous cell carcinoma. And then you will have your just a little bit when it comes outside, where it is known as rolled out edges, typically like a pearl, it will come out. This kind of pearly edge it can come out. So that kind of thing, of course, happens in your BCC, which is your rolled out edges, rolled out or pearly edges, which will commonly happen with your basal cell carcinoma. Then you have your undermined edges. So in your undermined edges, it will be overhanging. So it will come like this. Okay, so that kind of edges will come where it will be overhanging edges. And I draw it again. So the overhanging edges will be something like this. Overhanging edge or the undermining of the edge. Here you can see that the ulcer is extending much beyond. So this edge you can see is small lesion, but actually if you look at it deeper, it goes on. So that kind of edge is known as the undermined edges. These are the questions that are commonly asked. Simple questions we may think, but they do come routinely. So one example of this undermined edge is your pyoderma gangrenosum. It happens in inflammatory bowel disease, inflammatory conditions like rheumatoid, Wagner's, and all that. And treatment is management by steroids. In some cases, treatment of the underlying condition will help in treating with the condition. Now, this is what I said. We'll have a discussion on Boonville's disease. This is your tuberous sclerosis or Boonville's disease or adenoma sebaceum, where you have the facial angiofibromas. Classical facial angiofibromas. Treatment is by organ laser or other type of laser. And this is your classical rhinophyma. Rarely, less than 5% is associated with your basal cell carcinoma. This is rhinophyma, which is extreme nasal acne rosacea. And this is going to be your trichilemo or nevus sebaceous of Jadosum. These are very complex names which are given in Bailey. Unfortunately, they have the tendency to ask questions from Bailey in this chapter. So just have a look at it. You can see that verrucous lesion is present, especially common in the headache areas. And here there is a risk of going on for developing BCC. Right. So this is your classical milia, skin lesions, heat related thing. So there is a plugging by keratin. So this keratin retention will lead on to the formation of milia, and cysts are similar in a larger bullous area. If they form, then it is known as a cyst. So this will happen due to sun exposure classically. In summer season, we can very commonly see it. Then, of course, you have your sebaceous cyst or epidermoid cyst, as it is called as epidermoid, or the misnomer is actually sebaceous cyst. It does not arise from the sebaceous gland. It is an epidermoid cyst with a punctum, and you will have the formation of a material with the necrosis, with the sebaceous kind of material, cheesy material you will find inside. So that is your stratified squamous epithelium leading on to this. There is a blockage that leads on to the punctum. This is a scrotal sebaceous cyst. It can, of course, happen in multiple areas. Now, skin substitutes, these are some things that we need to know about. So you can use skin grafts, you can use acellular dermal matrix, you can use SSD or full thickness grafts. All these can be done. So if you look at it, ADMs, acellular dermal matrix, they can be taken from human sources, or they can be taken from xeno sources, or they can be, kind of like other things as well. So these are composed of collagen basically, along with the other fibers like liposaminobutyric, elastin, laminin, and all that combined together is what is known as your acellular dermal matrix. The time for incorporation is 1 to 2 weeks, and they may be applied on extensive large raw areas like in case of burns or in major trauma and all that. You may use them. Acellular dermal matrix can be used. They can be used as a bridge for graft. So there are two types. One is the temporary type, and the other one is the permanent type. The permanent type, you don't need to remove the ADM. You can just leave it in place. In the temporary type, you have to remove it before you, graft it. So these are, used in areas where you have a widespread area of involvement of vital structures, rather exposure of vital structures like exposed nerves, vessels, tendons, bones, cartilage, whatever it is. Whenever you have this kind of thing, there you can use your acellular dermal matrix, which is essentially made of collagen and the other fibers. It can be autografts taken from other areas, can be allograft. This is for not for the ADM, this is for coverage of the skin lesions. So you can use autografts, allografts, xenografts, or you can use tissue substitutes that can be like ADM. So actinomyces, again, we all know about actinomyces. The actinomyces foot, which is mycetoma foot, is very, very common, which is known as your Madura mycosis. And then you have your actinomyces burgdorferi. This is the false statement here. Okay, so the most common one is also not your Madura mycosis. So in India, it is very common. The worldwide common form is your cervicofacial form. So cervicofacial is the most common form of actinomycosis. In India, you do get the the foot one. The common organisms are going to be Actinomyces israeli. So most common is cervicofacial, usually in the paramandibular areas, and then you have your foot, which is known as your Madura mycosis. I remember was mentioned in Kushiri or one of the earlier books, this Madura mycosis. Nowadays, books do not even mention it, but in South Tamil Nadu, it is quite common. We get this Madura mycosis. Positive organisms, Actinomyces israeli, and usually treated with penicillin. IV and oral penicillin are the management. In large cases, when the tumor is kind of become woody hard and the skin is gone, in such cases, necrosis, poor response to antibiotics, then you may need for a surgical debridement and a graft or a flap or something like that may be needed. So when you talk about HPV and skin infection, we all know that HPV is related to mucus cancers, but the classical feature that we have is HPV 1, 2, and 4 commonly cause the verrucae vulgaris or the common warts. They are caused by your HPV types 1, 2, and 3. Here there is no treatment which is needed for verrucae vulgaris. And you also have other types, HPV 5 and 8. Okay, epidermolysis verruciformis with ability to transform to HCC. When you look at the SCC chapter, for example, these types will be mentioned. HPV 5 and HPV 8 are associated with that. This is for the cutaneous SCC. For the cutaneous SCC, the HPV type 5 and 8 are important. 16 and 18 are important for the mucosal HPV types. The 16 and 18 are important for the mucosal HPV types. And the hallmark will be the presence of coelocytes, which are clear halo around the nucleus, which will happen with your HPV DNA infection. So HPV or any kind of virus will basically bind to the human DNA and then it will exert its effect. So here you will have the characteristic presence of poilocytes, which is a clear halo around the nucleus, which will happen in your HPV DNA related disorders. And HIV and cutaneous infection, if you look at it, the most common viral infection is going to be herpes simplex. So commonly you will get your herpes simplex, which will happen. The most common cutaneous malignancy overall is going to be BCC. The risk is going to be around 5%. The sarcomas are the most prevalent. If you take a Kaposi sarcoma, this is the most prevalence. So prevalence is around 30%. This is not incidence, my friends. That is why even though it is 5%, the highest risk is there for BCC prevalence, because Kaposi sarcoma patient tend to go on with the lesion for a long time, whereas the BCC will be removed. Kaposi sarcoma, they will just tend to stay there, so it will be having a higher prevalence. So then we talk about the pre-malignant conditions. So here we talk about actinic keratosis. Now let's take this question. Actinic keratosis, which is the false statement here, they can regress spontaneously. 30% transform to invasive squamous cell carcinoma, 60 to 65% originate from actinic keratosis, and treatment can be excision by medical methods like cautery, restriction, 5-fluorouracil, dermabrasion. All this can be done. So these are the statements that are made. Can they regress spontaneously? The answer is yes. Transformation to 30% is a little high. It's, I believe, around 10 to 20% should be the number that will be quoted. 10% usually, up to 20% it can go. Other two statements are true as well. So 30% do not transform. As I said, it's around 10% to 20% that will have a transformation to squamous cell carcinoma. Many of the squamous cell carcinoma lesions, especially in the exposed areas, are believed to originate from your actinic keratosis. Now, this may be a picture that may be given. Classical sunburned appearance that you have in the sun exposed areas like scalp and face. Usually in the white population, this is common. Indians, not so common. So Indians, the cutaneous squamous cell carcinomas are not that very common. So if at all it happens in the white population, then they have a pre-existing actinic keratosis, and then that will transform to malignancy in about 10 to 20% of cases. You can excise, you can apply imiquimod, 5-fluorouracil, dermabrasion. All these can be used, and they can also regress spontaneously. That is also a chance that they can regress spontaneously. And sebaceous horn, classically we talk about the widow Dimanche. The widow Dimanche, which is one of the iconic pictures of Bailey, is based on the sebaceous horn that you have. So in a watercress cellar in which Bailey happened to notice. So that picture is found in almost every Bailey. So something similar. Basically, your diameter of the base should be less than half of the height. So height is greater than the base diameter. Whenever you have that kind of criteria, you can see that the height of the lesion is much higher. This is known as a sebaceous horn. Here again, there is a 10% transformation to malignancy. So it is better to excise these lesions. So these are the various melanocytic lesions that we have, again, which may come as a question for your examinations. So this waxy lesion that you see here is your seborrheic keratosis, which is the most common benign lesion. Now, this will have a waxy appearance. You can see that it looks like wax paper on the surface. So this waxy paper appearance is classical of your seborrheic keratosis. Then you have your nevus. Junctional nevus is the most common. It is called junctional because it is present at the dermo-epidermal junction with the proliferation of melanocytes or nevus cells. The Spitz nevus is another entity which is called as a juvenile melanoma. It is called as juvenile melanoma, but it is usually a benign lesion. The problem is sometimes it can be mistaken for a melanoma one, and there is something called as a Spitzoid melanoma, which will present similar to this. So commonly present in face and legs, usually in young children. You can see that it is a reddish brown lesion which will be seen. Excision is needed to rule out a malignancy. Now, spindle cell nevus will contain spindle cells, will have a malignant potential. This is a halo nevus. Classically, you can see the central lesion and surrounding depigmented area, and it will be seen in your vitiligo. So any of these may be kept as kind of image-based questions, and dark spotters or something related to that may be asked for you, right? And this is again the ABCD, atypical or dysplastic nevus that you have. So here you have the ABCD features. All of them have been marked out here. So asymmetry in shape. So it is not a very regular shape. You have an asymmetry in shape with the borders. You can look at the borders are also irregular. It is not a smooth outline like this. You can see that the border is irregular here. It's undulating, irregular borders is what you are seeing here. So that is known as your border irregularity. Asymmetry is the shape is not routinely like this. It will be somewhat different. It is not a classical. You can see that here it is not a classical shape which you get. So that kind of difference is going to be found. That is known as asymmetry, border irregularity, color. Again, you can see some areas which are high colored, some which are very pale, some which are indeterminate. All of them can be seen in the same area. So color variation inside the nevus is common. Then you have your diameter more than 6 mm. So evolving or evolution or change with time. So that is your ABCD features. So evolution or change with time is also going to happen. So all these features, when they are present, that is known as your ABCD lesions. The numbers again are more than 6, so more than 5. There is a 6-fold risk of being melanoma in case of FA triple F. Okay, so number when it is more than 5, and all these will require a lifelong training. FA triple M is one of the conditions where you have a risk of melanomas, you have a risk of pancreatic cancers, and again head and neck cancers as well. As we were discussing the head and neck chapter, this was one of the conditions which is involved with your hereditary head and neck. One of the few conditions where you have a familiar tendency for head and neck is your FA triple lesions. There also it can happen. So asymmetry, color, border, asymmetry, border, color. Then you have your diameter, which is more than 6 millimeter, and then the presence of your evolution or change with time. So all these are going to be present. They may ask you what are the features which are seen here. This is again a very classical Mongolian spot. Any of you in your labor or postings would have seen that babies are born with it, and there is a spontaneous regression by 7 years. This will be commonly present at the sacral area. And this is, of course, the speckled nevus, nevus pilus or speckled lentiginous nevus. You can see that there are a lot of dots inside the nevus, resemble the Caffioli spots, but it's speckling throughout it. Management is just again observation and follow up. Now, this is an entity which is suspicious, or rather, there is a high degree of transformation to malignancy. There is a 5 to 10% chance that it may become melanomas. So, the size of a giant pigmented nevus, giant congenital pigmented nevus, is more than 20 centimeters. That is going to be a criteria that will be asked. It will be more than 20 centimeters. Okay. Now, these questions have actually. So, what is this? What is this? So nevus of Ota, nevus of Ito. So Ota will happen in the face. So Oriental Africans, female greater than male, happens in the usually in the V dermatome. That is the segment 5 in the trigeminal dermatomes. V1 and V2 is where you will get the distribution. So this is known as nevus of Ota. This has come as a question. In the same exam, they asked about the nevus of Ito as well, where the similar bluish gray macules are going to be present in the shoulder or in the chest region. That is known as your nevus of Ito. Now, this is your classical blue nevus. Now, this blue nevus happens again in the face and extremities of children. This is a very benign lesion. This is a very benign lesion. The problem with blue nevus is both on histology and on clinical appearance. It can resemble a melanoma, and that is the only reason why we need to differentiate between the two. Right, now about the benign vascular malformations. What is this? This is your port wine stain, PWS, or your port wine stain. This is your strawberry angioma or a capillary angioma. It appearance which resembles a strawberry or a capillary. This is your capillary hemangioma, which is your strawberry nevus. This is the most common cutaneous vascular lesion, and this is the commonest birthmark, very common in females. And again, just like other lesions, disappears by 7 years of age. Commonly, girls are affected 3 times more commonly than boys, and every year around 10% will solve by 7 years, almost 70% of them, or many of them will get resolved. And this one, what you have is your salmon patch. So the salmon is a fish which will be pink in color for people who are familiar with that. So the salmon pink color appearance in the nape of the neck, usually this will also disappear by 1 year. The lesion which will not disappear is your port wine stain. So this you can see is a much, it's a much richer color. You can look at it, it looks much more richer, much more deeper. It is a vascular malformation. It is not a vascular lesion. It's a vascular malformation, and it is less common than a hemangioma. This one will need a pulse dye laser for treatment. So pulse dye laser therapy is needed. The distribution is again in the V2 and V3 dermatomes here. There is a defective cutaneous sympathetic innervation leading on to opening up the channels, and that is why you get this lesion. And here you have to treat it by laser therapy. It will not disappear on its own. And then, of course, the common lesions that you get, these are the freckly lesions that you get in old age. So these are known as the Campbell de Morgan spots happening in the sun exposed skin of older individuals. Nothing needs to be done for these kind of lesions. Then you have your spider nevi or your spider angioma. So this will happen in terms of pregnancy, liver disease, cirrhosis, all this it can happen. And of course, you have, just like your pyoderma gangrenosum, you have your pyogenic granuloma, which are small nodular lesions with superficial ulceration that will be commonly found. And then you have your glomus tumors. Now, glomus tumors are subcutaneous arteriovenous shunt that will form from the Sackett-Foyer canals that will get involved in this kind of thing. Small size, and there is a disproportionate pain. So if they give you a lesion like this and they say there is typical disproportionate night pain, and these are common in the nail bed as well. So when you have that kind of presentation, then you know the answer that you have to mark is a glomus tumor. And the most common melanoma, right? Now going on to the subtypes of the melanomas and the squamous cell carcinomas, we have to know about the subtypes. So in this, which is the most common melanoma, which is the most common basal cell carcinoma. So there is a slight degree of confusion that some people tend to have. Remember, for melanoma and for BCC, BCC is the nodular variant. BCC is the nodular variant, whereas melanoma is going to be the superficial spreading type. Overall, the most common cancer throughout the world is going to be your basal cell cancer, but it is not reported in tumor registries. Many of these lesions will be excised by dermatologists. Some of them will come to our attention. So overall, the most common cancer, human cancer, is actually basal cell carcinomas, and this is not reported in registry. So in many of the data, it is not included. Even if you look at the Globocon data, if you look at the Globocan data, it will be mentioned as plus or minus skin lesions. So plus or minus BCC, they will ask you to select whether you want to select BCC or not, or include it or not. Then what is the causation? We all know that UV rays, all the UV rays are dangerous. Both UV, B, C, everything is dangerous. Order is C greater than B greater than A. But of course, C will be getting filtered by the ozone layer. C is generally filtered by the ozone layer. So clinically, if you ask which is the most important or dangerous UV rays, that is going to be UVB. So the exam answer should be your UVB, which should be the most important one. And malignant lesions in the upper lip are usually basal cell carcinoma. Okay, malignant lesions in the upper lip are usually basal cell carcinoma due to sun exposure. The most common type is the nodular. We are just now discussing about the edges, so we all know about the presence of the pearly edges. The classical edge that we describe is a pearly edge, which is nodular. So just remember that, and that is the reason why you will have your nodular BCCs, which will be common. Nodular type and the nodulocystic type constitute around 90% of all basal cell carcinoma. One other feature that you have in BCC is there is no precursor lesion. There is no pre-existing lesion. For melanoma, you have got the various type of nevi. For your squamous cell carcinoma, you've got acne keratosis and other lesions like margins, etc. that can lead on to it. But when you take a BCC, there is no precursor lesion which is available for BCC. Then you have your field fire type, which is the most dangerous type of BCC. Field fire, like here, this is the classical field fire type of lesion. You can see that one area here is active, whereas this one, if you look carefully, this is a healed area. So if you look at a field fire, it will start off very rapidly and spread, but areas behind it will get healed. So that is why it is called as a field fire BCC. It is the most aggressive variant associated with type 4 collagenase secretion. So that is why it causes destruction of the cells along the pathway, and it keeps on spreading but healing behind it. So the healing ulcer with the spreading margin, that is a classical of your morphiform or field fire type of BCC. Now, the management of BCC is excision. Classical treatment is going to be excision. Rarely you can use other modalities like most micrographic surgery, radiation, cryotherapy, etc. can be used. Now, the margins, what is the margins that you will give? So the answer is a 4 millimeter margin for low risk. So low risk is anything less than 2 centimeters. Again, in the mask areas and all that, I'll be teaching about you later. And there is no immunosuppression. So basically, whenever there is a low risk lesion, 4 millimeter margin is going to be sufficient. Whereas a high risk lesion will require a 1 centimeter margin, which is more than 2 centimeters in the mask areas, in the head and neck and face, scalp, etc. Associated with immunosuppression. All this, when it is there, then you need a 2 centimeter excision. Now remember again, but in critical areas like this, when it comes close to the eyelid, or here in the inner canthus, outer canthus, these are common areas where you can find it, and that kind of thing is present, then you will have to make sure that you excise the lesion with minimal margins. There is no need to excise with a wide margin in such areas. So now going on to melanomas. So the most dangerous type of UV clinically, I already said it is going to be UVB. Okay, so clinically here the key word is clinically. If they have not mentioned this word and they have just said which is the most dangerous type, then the answer is going to be UVC. But overall, because the ozone layer will absorb UVC, the answer is clinically important one is going to be UVB. Now, UVA exposure is something which is associated with your tanning beds. Okay, there are some people in the US and in Australia where they have something called as tanning beds, where artificially they will get tan. So this kind of thing is common, and that exposure can lead to high risk of melanoma. Now, the type of sun exposure in melanoma is also important in various skin cancers. Now, chronic exposure. This chronic exposure is important only in squamous cell carcinoma. In both melanoma and in BCC, we get an intense intermittent sun exposure. That is the reason why tanning beds are important in development of melanomas rather than your SCC. Chronic sun exposure, as I already said, is important for your squamous cell carcinoma. The hereditary syndrome is known as your BK mole syndrome or your familial atypical multiple mole melanoma syndrome associated with the CDKN2A locus. This is present in the most common form of FA and overall, if you look at it, which is the most common mutation in melanoma, then the answer is going to be your BRAF, which is the V600E mutation. This is the most common type of mutation that you will find in your sporadic melanoma. So in inherited melanomas, the answer is CDKN2A in FA whereas in case of your sporadic melanomas, it is going to be BRAF V600E, which is the most common type. So which is the risk type? All are risk types. So Fitzpatrick type, yes. Xeroderma, yes. Family history, yes. Asia Pacific Islander is actually protective. Men is greater than women as far as the, generally speaking, men will have a higher chance of developing melanoma, plainly because they have more of sun exposure. Because of sun exposure, they will have a more this one. And among the races, if you look at it, Africans have the best protection, and then you have the Asians and Asia Pacific Islanders who will have the least this one. So this is the least risk, and then this will be the second least affected as far as melanomas are concerned. So Asia Pacific Islander men and women have the lowest incidence after black men and women. So Fitzpatrick, basically the tall blonde, the Aryan ancestry as we call it, the tall blonde types with the blue eyes, with the blonde hair and all that. These are the risk factors for developing melanomas. So Fitzpatrick type is also a risk for squamous cell carcinoma. Xeroderma pigmentosa, FA all these are the hereditary forms of melanoma that are prone for developing melanomas. And intense intermittent exposure, UVA in tanning beds, all this is what we saw. Now, whenever we talk about UV, there is a UV associated mutations. There will be classical DNA adducts that will get formed. This can be seen in melanomas when we study them in the genetics. So that is a classical, what we call as a UV signature. There will be a signature, UV signature that will be formed by which you can identify. Now, identify the wrong statement about melanoma here. 40% arise from precursor lesions like the dysplastic nevus. BK mole syndrome is associated with CDKN2A mutation in almost 40% has multiple melanomas and then associated with pancreatic cancer. Giant congenital nevi greater than 10 cm have an increased risk of melanoma and are preferentially excised. Spitz nevi with atypia are managed by wide excision similar to a melanoma but do not require an SLFP. So the correct answer here is of course 10 cm. We just now discussed in nevi, GCPN, that is giant congenital pigmented nevi, have a diameter of more than 20 centimeters and they are associated with the risk of melanoma. So this is again another form of GCPN that you are seeing here. So the BK mole syndrome or the familial atypical melanoma, multiple mole melanoma syndrome associated with CDKN2 mutations, multiple nevi, high risk of malignancy, almost 40 to 50%. Okay, and GCPN, as I already said, is 20 centimeter. Spitz nevi, as I already said, whenever a Spitz nevus is there, it is a benign condition. But Spitz nevus with atypia can be difficult to distinguish from a melanoma. So the lesion is again excised widely. SLNB done with the later date only if we confirm that there is a spitzoid melanoma. So you'll do a wide excision alone whenever a Spitz nevus kind of lesion is suspected based on the clinical features. Wide excision alone is done. SLNB will be done at a later date. And 40% of melanomas arise from a pre-existing nevus or a congenital or a dysplastic nevus. So melanoma mutations, as I said, which is the false statement, all are true except. Okay. So BRAF is the most common type, correct. So there are other subtypes which are going to be found, RAS, P53, and NF1. Here, of course, the answer is very clear, which is the most common inherited mutation. The answer is not P53. We just looked at it. It is CDKN2A, which is found in your FA syndrome. So that is the most common inherited mutation that you have. So when you look at breast cancer, you have 3 mutations. So the same way in melanomas also, you have 3 particular mutations: the RAS, the RAF pathway, and then the NF1. All 3 are going to be the various pathways that are going to be found as far as your melanomas are concerned. The most common is your BRAF V600E. Second most common is BRAF V600K. Okay, these 2 are the BRAF mutations that we commonly found. The pathway wise, the second most common subtype is going to be the RAS pathway. So RAS and RAF. So RAF will come, BRAF will come first, and then you have the RAS pathway. And then you have your NF1 pathway, which is implicated in around 15%. When you have something like triple negative, so the same way you have your triple wild type, meaning all three mutations are not found. So then it is known as your triple wild type. This is the type which has the lowest UV signature as well. RAS RAF pathway and the NF1 pathway are affected by the UV signature. So if you look at it, this is your RAS. Then you have your RAF. RAF is the most common one. So this is the first pathway which is affected. This is the second one which is affected, and NF1 is also implicated, which is the third most common, which has an inhibitory effect on the RAS as well. So when you look at the other things which can be stimulatory are going to be EGF mutations, PDGFR, IGF1R. All these are some things that can lead on to activation of the mutation. And then you have the PIK3K pathway, which is the second pathway where you can have development. That is where you will have RB1 gene, the CDK inhibitors, which will come in P16, the mTOR pathway. Like I already said in the various classes, there are two pathways. That is the PK3 pathway and the RAS-RAF pathway. Just remember the pathways. Most of the drugs will come under these pathways only. Okay. So now in the management of patients with melanomas, you can remember the BRAF inhibitors will come here. The BRAF inhibitors will be coming here. So dabrafenib, vemurafenib will come here. And then the MEK inhibitors are the next level. So if you look at it, the MEK inhibitors like cobimetinib, okay, cobimetinib and tramitinib, tramitinib. So these are the drugs which will be cobimetinib and tramitinib are two drugs. So combination of dabrafenib plus tramitinib or combination of vemurafenib plus cobimetinib. So these are two combinations that are currently preferred in stage 3 melanomas. So you use a dual blockade. One is the RAF pathway blockade. The other one is the MEK inhibitor pathway, which is cobimetinib and tramitinib. So both of these drugs will be used together in the management. And the reason for this is this particular pathway that we have here. So the RAS pathway we have, and then you have the RAS pathway and you have the RAF pathway. Both of them will be coming in here, and that is what you are using. So the RAS and the RAF pathway are the most important ones. The third most important one that you have is your NF1 pathway. All these three are commonly involved in melanomas. A combination of RAS and RAF inhibitors, RAF and MEK inhibitors are the drugs of choice in the management of your melanomas. Right. And loss of PTEN mutation will happen in non-familial melanomas. Now, this is again one pathway where you can have because downstream in the RAS and RAF, you can see that also activates the PAK3. So when you have a loss of PTEN, which will inhibit this pathway, PTEN is a tumor suppressor gene. When it is lost, again, that can be a resistance to a combination of BRAF and MEK inhibitors. Why this started is initially they started using the BRAF inhibitors. Then they found that they want to develop a resistance. So they started using the combination BRAF plus MEK. Now, when that happens, the melanocytes, they become a little more smart and they go and inhibit this PTEN. So this PTEN gets lost, and so it follows a different pathway. That is where you can use your mTOR inhibitors like everolimus. So various pathways exist in essence. So when you look at melanomas, young people, the most common cancer in young adults is your melanoma. In the 20 to 40 age group, the most common cancer in young adults and associated with a high degree of mortality is a melanoma. So there is only one type of melanoma which is associated with your chronic UV exposure, that is known as the LMM or the lentigo maligna melanoma. So lentigo maligna is a precursor lesion that will go on to transform to lentigo maligna melanoma. This is the subtype which is associated with your head and neck exposure. Head and neck areas that will commonly happen, it is associated with your chronic sun exposure. Overall, the most common type is going to be your superficial spreading. So as I already told you, in BCC, remember the pearly edges, so it is nodular, most common type. The same way in melanomas, it will be like a mole, so that is your superficial spreading lesion. Now, UV exposure to UVB most commonly, and UVA and tanning beds are going to be important. Molecular pathways we already mentioned and we had a discussion about here. Now, which is the preferred biopsy for a 1 centimeter melanoma? Now, remember, whenever you have got a small melanomas, you can excise the lesion. Like up to 1 centimeter here, the lesion will be excised with the margin of 1 millimeter. So it depends on the size of the lesion. Small melanomas, you can excise with a 1 millimeter margin. This is the preferred biopsy for a small melanoma. On the other hand, you can do an incision or an edge wedge biopsy. You can take a biopsy from the edge of the ulcer like this. You can do an edge wedge biopsy as we commonly do, an incision biopsy. The other one is something called as a dermatological punch, which is what is being done here. You can see that there is a lesion there. So with the dermatological punch, they just go in and then they take it out and then they cut it and remove it. So this is known as your punch or drill biopsy. It is not the punch that we use like a plier. This is a dermatological punch which we will be using. I already mentioned it in, I think in breast, you can do a punch biopsy for Paget's disease. So this is your punch. Basically, it will be like a screw kind of thing. You just roll it around, go deeper. Here the depth should be at least 4 millimeter again through the thickest part of the lesion in a large lesion. When you have a very large lesion, for small lesions, actually such a lesion will be excised with a 1 millimeter margin. Find out the pathology and then you will go for wide excision with sentinel lymph node as a second step. On the other hand, when you have a big lesion, you will go through a punch through the thickest part of the tumor. Wherever it is appearing very thick, that area you will go and access through a punch or a drill, and then you will take a biopsy. Then you have your shave biopsy, where you will excise this lesion with leaving behind tissue at the base. Now, this will not leave the correct depth and hence it is not preferred. This is done by dermatologists. So now they have changed their thing, which is something called as a deep shave biopsy, complete removal up to the level of the subcutaneous fat they do. This they say is an OP procedure where you don't need to kind of like give anesthesia and all that, etc. I mean, instead of a surgical excision, they do it. It's something similar to what we do. So deep shave can be done, but a shave biopsy is something which is usually contraindicated. It should not be done except by some dermatologists who continue to do that. So as far as the biopsies are concerned, whenever a lesion of 1 centimeter, less than or equal to 1 centimeter, then you can do an excision with 1 millimeter margins. Okay. All other lesions, you use a punch or a wedge or what you can call as an incision. Any of these, when it is given, you have to choose that as the option. Right. What is this melanoma? Just now we were discussing. This is our lentigo maligna melanoma. This is your classical lentigo maligna melanoma. You can see it is happening relatively an elderly person, happening in the head and neck and face area. It's kind of like a superficial spreading type of thing. So this is also known as the Hutchinson's melanotic freckle. Elderly, commonly seen in women, face and head and neck areas. It will commonly happen. Slow growing lesion associated with your chronic sun exposure. Generally speaking, it will have a late entry into the vertical growth phase. As we know, there are two growth phases. One is the RGP or the radial growth phase, and then you have the vertical growth phase. Generally, in your superficial spreading melanoma, the RGP will be greater than the VGP. Nodular melanomas, on the other hand, they will straight go into your vertical growth phase. So that is why the nodular melanomas are dangerous. That is why the nodular melanomas are dangerous, because they will straight away go into the vertical growth phase. Now, this is another example of an elderly gentleman with a similar lesion in the face. This is also a Hutchinson's melanotic freckle. This can come as a straight MCQ for you. What is the type of lesion? Now, most common melanoma and then the most common melanoma in non-big. So we know that here it is either C or D. We know the superficial spreading is the most common. Now, is amelanotic the most common type, or is it acral lentiginous? The answer is acral lentiginous. Now, acral lentiginous is a type of melanoma which will be found in the hands and feet very commonly. Again, in the non-white population, in Asians, that is where you will get it commonly. Remember, though we say that sun exposure is important in melanomas, the superficial spreading one will happen commonly in the trunk and in the proximal extremities, that is in the non-sun exposed area. So it is, it's a kind of like, conundrum why it happens, but related to intense sun exposure, but the ability to develop a melanoma commonly in elderly population, in the Western population, we find that the superficial melanomas happens in the trunk, in the non-sun exposed areas in the trunk, and then in the proximal extremities, which are usually covered. That is where you will have the melanomas that will happen. Acral lentiginous, on the other hand, will happen in the periphery. This is the most common type that will happen in the non-white population. Subungual melanomas is again considered to be a variant. This thing what you have here is a subungual melanoma. This is an acral lentiginous type. This is again a this is an acral lentiginous melanoma. So here you have to do a punch biopsy through the nail of the lesion. When you have something like this, you have to do a punch biopsy through the nail of the lesion in the early phases. Here, of course, it has come out, so you can do a wedge and you can do. On the other hand, if it is under the nail bed, then you have to do this one. So here, if you look at the various types, this is your superficial spreading type. This is going to be your nodular melanoma. You can clearly see this projecting out from the surface. This is going to be your lentigo maligna melanoma type. This is going to be your lentigo maligna melanoma type. This is your superficial spreading melanoma. This is the nodular melanoma which you have. This is your subungual. melanoma that you are getting. This is the acral lentiginous type of melanoma. So all these are present here. Okay, so these are again another this one. So superficial spreading, non-sun-exposed areas, trunk and proximal extremities. Nodularity happens with the vertical growth phase. This is a classical nodular melanoma, which is the second most common type, probably around 15% of cases. This is more aggressive and they arise de novo. They do not have a radial growth phase. They straight away, they do not arise from a mole. They straight away arise de novo. And 5% of these can be amelanotic. Amelanotic basically means the color is not that, is not considered to be a separate subtype. There are various, any of the subtypes can be amelanotic. It can be superficial, it can be nodular, it can be lentigo. Any of these may present as an amelanotic tribe. And again, nodular is common in the trunk and in the head and neck areas, sharply demarcated. It is more aggressive. Lentigo maligna, as we just said, elderly females, common association with chronic sun exposure. Now, what is this change which is present here? This was a tactically placed question. If you look at the notes, you'll understand that this is just observation that we need to do. This is a benign racial pigmentation. What we have here is a benign racial pigmentation. We can see the difference between the two. You can see that the nail fold is normal. Okay, whether the nail fold is normal or not, you can see that the nail fold is completely normal here. On the other hand, you can see the tumor which is extending onto the nail fold in patchy areas here. So that is the difference between a subungual melanoma, which is your, melanoma under the finger nail. The nail fold pigmentation with nail dystrophy will happen. It is known as the Hutchinson sign. They may ask you this, give the picture and ask you the sign. They may ask you the diagnosis, which is a subungual melanoma, Hutchinson sign. What is the diagnosis? Here you will do a punch biopsy or a drill biopsy through the nail bed. You have to do in case it is confined without coming out, where you cannot do a biopsy. And so acral lentiginous, other melanoma subtypes common in schools, especially in the Asian population. And here 25% can be amelanotic. So amelanotic is a broad definition. It can apply to nodular, it can apply to superficial, it can apply to any type where you have the pigmentation which is lost. Okay, so you have your acral lentiginous where you have the Hutchinson sign, and this is the most common melanoma in non-white population. Now, subungual melanomas are mentioned as SSM in Bailey, acral lentiginous and subsistent. Usually, I think we will group it along with the A&M. So I think if they ask you which subtype is acral lentiginous melanoma, I think the answer should be marked as acral lentiginous. It does not group under SSM. Actually, SSM is a separate entity. Generally, in the palm, generally when we talk about it in the other areas, we talk about it as SSM. In the in the peripheries, whenever a melanoma happens, we group it under the acral lentiginous melanoma. Okay. And other thing is subungual melanoma does not change position with time. On the other hand, if you have a hematoma under the nail bed, that will keep growing and keep growing distally. So the hematoma will move distally, migration distally will be present, whereas the subungual melanoma will not move distally with time. That is another differentiation between the two. There is another special entity called as desmoplastic melanoma. Now, more than 95% or 90% of the lesion needs to be combined of a desmoplastic component to be called as a pure desmoplastic melanoma. The importance of this is it has got a high degree of perineural invasion and high chance of local recurrence. But at the same time, it will have a less of propensity for nodal metastasis. So this is a very, kind of a contradictory point. You have a high local recurrence, but low chance of this one. The reason is PNA is there, so it causes high local recurrence. On the other hand, it causes a dense desmoplastic stromal fibrosis. That is why it will not spread to the lymph nodes. So combination of stromal fibrosis and the PNA, both of these together, leads to the combination of high local recurrence but less of nodal metastasis. So this pure desmoplastic melanoma, some people say you can avoid an SLNB, but currently most people still follow the same thing, whatever be the subtype, except for the depth of the lesion. All other melanomas more than or equal to 8 millimeters in depth need a sentinel lymph node biopsy in management. Right. Now going on to the correct M stage as far as the AJCC classification is concerned. M1A is lung, M1B is distant skin and nodes, M1C is distant soft tissue, and M1D is your CNS metastasis. So this is the classification which is given as far as the M stage. So here, if you look at it, the most common one, identify the correct stage. So here you have to think about it as distant skin and soft tissues will come under M1A. Okay, so the distant skin and soft tissues will come under, and distant lymph nodes will also come under M1A. M1B is going to be the lung. M1B is going to be the lung lesions, and M1C is going to be your visceral, all other except the CNS. And M1D is going to CNS metastasis. Okay, so the increased chance or the poorer prognosis is with the poorest prognosis with the CNS types. So in all of this, the LDH levels, if it is normal or abnormal, so if it is 0, that means it is normal, and if it is 1, it means it's a raised LDH. That is the subclassification of the melanoma. So basically, M1A is skin, soft tissue, and distal nodes. M1B is lung. M1C is going to be your visceral metastasis, except the CNS. Like, it can be liver metastasis, it can be other. Melanoma is commonly something that will go to the small bowel deposits. In fact, the first surgery that I assisted in Adyar Cancer Institute was a patient with a small bowel resection, which we had to do for a deposit from melanoma. My consultant asked me at that point of time, I just finished my PG exams and everything like on that. So, he asked me what is likely to be the type. He was thinking in terms of an adenocarcinoma. It was not a very, melanotic lesion. So there was just a mass forming lesion. I said it is more likely to be a melanoma, sir, because metastases are more common. So I think it's a melanoma. And, that was my first day. I just went there, assisted the case and came out. Then I was posted in a different department once the things got in place. And then later on, he called me and he asked me, did you know what is the pathology of that? And that turned out to be a melanoma. You were right, it was a melanoma. So, that is why it's stuck in my head. And, that is something which we read. Small bowel metastasis. Unusual site of metastasis is small bowel. That will happen in your melanoma commonly. So that kind of visceral metastasis will come in your M1C. Okay, right. Now, when we talk about the staging of melanomas, you have your thin, thick. Thickness is the most important prognostic factor in N0 disease. Now, melanoma, whenever they ask about prognosis, it is the N status, which is the most important status. Okay. In N0, which is the most important prognostic factor, there it is the thickness. Okay. And when we talk about thickness, what is the thickness that you have to see? Whether it's a thin melanoma or a thick melanoma, that is less than or equal to 1 millimeter or greater than 4 millimeter. Okay. So less than or equal to 1 will come under the thin. The other two will come under the thick. So 1 to 2, 2 to 4, and more than 4. Now here, I just want to highlight one more thing. There was one girl who asked it, and yes, there has been one change. Initially, when the AJCC came, based on that, I gave you a staging. Now there is actually a slight change that has happened with regard to the head and neck. Kindly note this down, my friends. In head and neck, I told you with the T staging, T1 is basically less than or equal to 2 centimeter and less than or equal to 5 millimeter. And I said anything where it is T4 is going to be, T3 is going to be more than 4 and more than 10. Okay. So here the answer, the correct way to look at it is actually like this. So T1 is less than or equal to 2 centimeters in size and less than or equal to 5 millimeters. Okay. Now T3 is going to be either more than 4 centimeters or it is going to be more than 10 millimeter. Meaning, if you have a lesion less than 4 centimeters and more than 10 millimeter, or if it is more than 4 centimeters and less than or equal to 10 millimeter, that is T3. When both T4A is where, other than the local invasion, you have more than 4 centimeters and more than 10 millimeters. Is it clear, my friends? Just whatever I told in T3, just converted to T4A. And remember, this is either or. Both of them together will make it a T4A. Whereas if only one is present, that is going to be your T3. Okay. So T1 is both. That is, the depth should be less than 5 millimeter or less, and size should be less than or equal to 2 centimeter. T3 is going to be more than 4 centimeters or more than 10 millimeter. One of these two factors should be present. Either the size is more than 4, but the depth is less than or equal to 10. Or it has to be the depth is more than 10, but the size is going to be less than 4 centimeters. Okay, that will come under the T3 lesion. Whereas the intermediate group will contain the other things, meaning what? It is greater than 2 centimeters and less than or equal to 5 millimeter, or it is less than or equal to 2 centimeters and between 5 to 10 millimeters. Okay, so that will come under the T2 lesions. So this is for head and neck I'm talking about. Again, don't get confused with other things. This is the head and neck. There is a slight change. I told you like T1 remains the same, T2 remains the same. T3 is greater than 4 centimeters or greater than 10 millimeter depth of infiltration. That is the only thing you need to remember. Okay. And T4A is where it is both more than 4 centimeters and more than 10 millimeter. Thank you. You sent it to me. Thank you for that. So I just had a re-verification and went through multiple things, and there was a change, and that is why this thing has come about. There were 2-3 changes that came in the AJCC classification after it was announced in head and neck. So one of them is this one. Okay, so basically this is the one, right? So in your melanomas, when you look at it, the T stage is thin melanomas is basically less than or equal to 1 millimeter. Okay, so in this, the real thin melanomas are up to 0.7 millimeters. That will come under T1A, and there is no ulceration. Okay, no ulcer, and it is less than 7 millimeter, 0.7 millimeter. That will come under T1A. Now, this T1A is the only one where there is no role for a sentinel lymph node biopsy. The T1 lesion is the only one. T1A is the only lesion where there is no role for a sentinel lymph node biopsy. All other lesions will need a sentinel lymph node biopsy. Then you have your T1B lesion, which is 0.8 millimeter to 1 millimeter, or if it is up to 0.7, but with ulceration. In general, grossly, when you look at it, for all melanomas, remember this classification will, you have to, it's a difficult thing to keep remembering how it works and all that. Okay, so the simple way is up to 1 millimeter thickness. It is a T1 lesion. In all melanomas, A and B is without ulcer, and this one is B is equal to with ulcer. Okay, then the thickness less than or equal to 1 millimeter, you already saw is T1. 1 to 2, greater than 1 up to 2 is going to be T2. Greater than 2 up to 4 is going to be T3. And greater than 4 is going to be your T4 melanoma. This will be the thick melanoma. And in all of this, whether it's without ulceration or with ulceration, the lesion, that is going to be your A or B. T1 is the only one where you have a subcategory T1A up to 0.7 millimeters. Again, without ulceration, when you have here, there is SLNV can be avoided. There is no need for an SLNV. So any lesion which is less than or equal to 0.7 with ulcer, or 0.8 to 1 millimeter, that will be making as a T1B lesion, and this one will need a sentinel lymph node biopsy. This one will need a sentinel lymph node biopsy. So this is the T staging. Now going on to the N staging. Now N staging also has the similar thing. So in essence, N1 is equal to 1, N2 is equal to 2 to 3, and N3 is going to be 4 or more. So this is the numbers wise thing. N1 is 1, 2 is 2 to 3, and 3 is 4 or more. Then you have your ABC. In ABC, A is going to be detected by SLNV, and C is going to be the presence of satellite nodules or in-transit metastasis. Now let us look at the number. Now N1 is something what there can be only one node which is positive. So N1A is what? Then you can detect it only by sentinel lymph node biopsy. On the other hand, what is B? B is clinical. Okay, so N1B will be what? There is only one node, so that node is clinically detected. Over. What is N1C? Then there is only one node. Nodes and satellites are taken together. So you have only one node which is there. That is the only nodal kind of spread is a satellite nodule or an in-transit metastasis. Okay. So satellite is less than or equal to 2 centimeters from the primary lesion. More than 2 centimeters from the primary is known as an in-transit lesion. Okay. So when you have a melanoma which is here, and there is another lesion which is present close to it, another satellite nodule is present, it should be less than or equal to 2 centimeters from the edge of the primary. If it is more than 2 centimeters away, let's say that this is 2 centimeters, if a lesion is present here, that becomes a satellite. On the other hand, more than that, when you have it, that becomes an in-transit. Have a lesion here, that becomes an in-transit lesion. Usually, in-transit lesions will be towards the lymphatic. Suppose we have the hand here, then you have a lesion here. Okay, and then you have another lesion here. Now, this lesion, what will you call it? Usually, it should be called, if it is more than 2 centimeters, it should be called as a in-transit, but this is away. Sometimes it can be more distal as well. Especially in the extremities, it can be distally present as well. But usually, it will be towards the direction of the lymph node basin. Usually, your in-transit will be in the direction of the lymph node basin, but distally also in the extremities, it can be present. Okay, so you are now clear with regard to the in-transit and with regard to the satellite modules, the cutoff point is basically 2 centimeters. Okay, less than or equal to 2 centimeters is a satellite, and greater than 2 centimeters will be called as an in-transit region. Okay, now if you look at end staging now, going back to the end staging now, easiest way to remember is the numbers. N1 is 1, N2 is 2 to 3, and N3 is going to be 4 or more. Okay, now in this one, A is always SLNB, B means clinical, and C means it is going to be satellite. What is N1A? There is only one. So the maximum number you can get is one of the node or the satellite nodules or in transit or anything. It can be SLNB, it can be clinical or this one. So N1 becomes very simple then. A is a node detected by SLNB. B is a single node which is clinically detected. C is a single satellite nodule or an in-transit metastasis. Over. That's it. So there should be no other nodes. And again, here there is clinical node, no other metastatic node which is present here. Right. So this is with regard to 1. Now let us go on to 2. What about 2 then? So when we talk about 2, so I said it is 2 to 3 nodes. Now in this 2 to 3 nodes, it can be detected by SLNB, then you call it N2A. Now if N2B should be at least one node should be clinically detected. Total number is 2 to 3. One should be at least clinically detected. In the same way, at least one should be a in-transit. Any in-transit metastasis is present, and along with that, if you have a combination, then it becomes an N2C. Is it clear? So A is, it's completely by SLNB only. B is clinical, which means in N2, this one is SLNB, 2 to 3 nodes. All of them are SLNB. As I already told you, N2 is going to be 2 to 3 nodes. So when we talk about A, it means that everything should be a sentinel lymph node. So 2 to 3 are sentinel lymph nodes. B clinical means at least one clinical node. It can be 1, it can be 2, it can be 3. Okay, any of the 3 combinations, but at least one should be a clinically detected node. In the same way, the combination of one node with one in-transit or satellite. Okay, one in-transit or satellite will be present, plus one SLNB or clinical node will be there, or it can be 2 SLNBs or clinical nodes. Okay, so the same thing when you look at it. Sorry, here again it has to be just one in-transit lesion and one clinical node. Okay, the number is 2 to 3 except for N2C. There is a slight difference that will come in here. Let me explain this again in case you have a confusion. So N1 is 1, very, very clear. 2 is going to be 2 to 3, except for C, which is only going to be 2. Okay, so A is SLNB, B is clinical, C is your satellite. For example, let's have it as satellite. Okay, or let us put it as C is in transit. Let us put S, C, and I. So A is equal to SLNB, SL we can put it. B is equal to clinical CL. I is equal to in transit. That is your C. Okay, so that is your N2 ABC. Now N1 is what? It has to be A, N1A is equal to 1S, one clinical node. And again, one in transit without any other nodes which are found. That is your N1C. Now, when you apply the same category to your N2, what will happen? So here, N2A, A should be only SLNB. So all 3 nodes or 2 nodes are SLNBs. The same thing, N2B can be 2 or 3. At least one should be a clinically detected. Now, here I have mentioned N1C is in transit or satellite without nodes. In transit or satellite with one node becomes a N2C. In the same way, in transit or satellite with 2 or more nodes becomes a N3C. So if you want to look at it from point of view of staging, just like what we saw for your head and neck cancer, the same way what you will do here you can look at in transit, whether it is yes or no. If the answer is yes, then the next question you ask is whether nodes are yes or no. Again, you look at whether it's positive or negative. If the answer is nodes or yes, then you look at the number is 1 or 2 or more. So if you have the answer as in transit, which is yes, okay, and you have nodes and the number is 1, then it becomes a N2C. So whenever it is N, this one, it already becomes N3C. So in transit, when it is present, then it becomes a C lesion. When you have associated nodes or not, if the nodes are not present, then it becomes a 1C. Try to draw it here in a different place. So you have in transit alone. If it is no, then you look at the lymph nodes. If it is not there, if the intransit metastases are not there, then it becomes either A or B. Then you look at lymph nodes. So lymph nodes, whether it is SLNB or whether it is going to be clinical. That is what you have to look at. So if it is only SLNB nodes, then you look at the number 1 or 2 to 3 or 4 or more. So if it is no, if the intransit metastasis is no, then it is not a C lesion. Again, lymph nodes is present only on SLNB, then what it is? It is 1 node, it is N1D. It is 2 to 3 nodes, it's N2A. If it is 4 or more nodes, always enter lymph nodes, it is N3A. Over. On the other hand, if it is lymph nodes, which are at least one is clinical, plus or minus, clinical plus SLNB, both put together, you look at the number. So this plus this, when you have both put together, the numbers are 1 means if it is a single clinical node, the answer is N1B. If it is 2 to 3 nodes, at least one which is clinical, then the answer is N2B. And then you have 4 or more nodes, at least again one node is clinical, then it becomes N3B. Right. Then going on to in transit, if it is present alone, if you have only in transit, then it becomes N1C. If it is in transit plus one node, then that is N2C. If it is greater than one node plus satellite, then it becomes N3C. Is this clear, my friends? Is this part clear? Is this classification clear now? How to group as N1A, N1B, N1C, etc. All this is clear now for all of you. I just want you to reply in the chat box and tell me. I'll just tell it again for your benefit. Okay. The way you have to group it is basically, the numbers are most important. Whether it is 1, the numbers can be 1, 2 to 3, or 4 or more. This is one classification. This will apply as far as the lymph nodes are concerned. And here, if it is only 1, 1A is going to be SLNB alone. As I already say, A means SLNB is present. Clinical, once it comes, then it straight away goes into B category. Okay. Whenever you have a clinical node, it goes into the B category. And whenever you have an in-transit lesion, then it goes into the C category. Okay. C category, transit or satellite will go into the C category. Okay. So the first question is asked is, do you have in-transit or satellites? The answer is yes, then it is C. Is it N1C or N2C or either it's 1C, 2C or 3C? So the first question, whenever you have a patient with a presentation of a melanoma, you look at the in-transit or satellites. If it is present, it is going to be 1C, 2C or 3C. If it is only satellite nodule without nodes, so N0 plus satellite, that is N1C. N1 plus satellite. N1 I mean is basically you have only one node plus satellite, then it is N2C. When you have N2 or 2 plus or 1 plus, you can have it. If it is 1 plus, anything more than 1, greater than 1 plus a satellite is there, then it becomes an N3C. Okay, so you look at whether satellites are yes or no. Satellite is yes, then the answer is C. So then it looks at nodes whether it is yes or no. Nodes are yes, and the number is 1, then it is 2C. This is 1C. Then if the node is 1, then it is 2C. If it is node is 2 or more, then it becomes 3C. Okay, so this takes care of the 1C, 2C, and the 3C. Then you have the clinical staging. Remember it as this way, otherwise SLNB staging. Now I said A staging is completely by SLNB. So if it is N1A, it is 1 SLNB. N2A is 2 to 3 SLNBs. And then 4 or more becomes 3A. So remember the 1A, 2A, and the 3A, and the 1C, 2C, and the 3C, whatever is left in between will come under the clinical stage. Okay. So remember, N1 is 1, N2 is 2/3, N3 can be 4 plus. So if everything is by SLNB, then it is N1A. Again, 2 to 3 SLNBs, then that is N2A. If it is 4 plus SLNBs, then it is N3A. Everything by SLNB, then it becomes a lesion like this. Then you have your SLNB along with basically you have only your satellite lesions that will become your N1C. If it is one node, either SLNB or clinical plus a satellite, then it becomes N2C. Greater than one node plus satellite becomes a N3C. So what is left? You have your 2B, 1B, 2B, and 3B. So what is 1B? I said it is only one node, so this one node is a clinical node. So 2B is going to be 2 to 3 nodes. Okay, so it has to be one clinical, at least should be there, and the other one, 1 to 2 will be SLNB. And then you have 2 nodes which are clinical, and rest plus SLNB is going to be present. So now we look at it. Total number is 1. 1 SLNB is N1A. Total number is 2 to 3. All SLNB is N2A. Total number is 4. At least all of them are SLNB is N3A. Then you look at the satellite lesions. So satellite is any satellite without nodes is N1C. Then you have one SLNB node or one clinical node with this one. So satellite plus one node is going to be N2C. And satellite plus 2 or more nodes is going to be your N3C. Then you look at the clinical nodes. So then you look at the numbers basically. So if it is only one clinical node, it is N1B. At least one clinical node plus other nodes, total number is 2 to 3, then it is N2B. Total number of nodes is 4, of which one is clinical. 2 to 3 are going to be, not 2 to 3, if it is 3 to 4 nodes which are detected. So 1 plus 3 will make it 4. So total number should be 4, then it becomes an N3 lesion. Is the N staging clear, my friends? Is it clear now? How do you say about the lymph nodes, sir? This is intransit. The nodes are not involved, lymphatics is involved. That makes it excision difficult, hence maybe stages. See, remember, wherever you have something like a satellite lesion, it may be here, it may be other, for example, in colorectal also you have a similar thing where it is grouped under this one. As someone had mentioned in the chat comment, this basically indicates that it has spread beyond the local tumor onto the lymphatics in the skin or elsewhere, and that is why all of them will be grouped under the category of lymphatic involvement. It comes under the N staging. So you have the non-node deposits which will be found in N1C in your colorectal cancer also, in CRC also, when you have presence of deposits outside the wall of the bowel, presence of deposits outside the wall of the bowel, but lymph node architecture is not made up, that will come under N1C. So the similar thing, wherever you have a picture which is similar to the nodes, there we call it as an N1C. So here also it will apply. Here it will apply for the satellite lesions. So only satellite is N1C. Satellite with one node, either clinical or SLNB, is N2C. The same thing, satellite with multiple nodes, either clinical or SLNB, is going to be N3C. Now, SLNB alone, if you look at it, the number 1 sentinel node is positive, that is N1A. 2 to 3 sentinel nodes are positive, that is going to be N2A. And then you have your N3A, which is 4 or more sentinel nodes which are positive. And again, the same numbers, one node, one clinical node alone is N1B. One clinical node plus 1 or 2 SLNBs is going to be, total number is going to be 2 to 3 only here. The total number has to be 2 to 3 only here for B staging. Okay, so for B staging, the total number remains 1 here. Here the total number is 1 for the B staging. So there is only one clinical node. So here again, N2B, the total number is 2 to 3, in which 1 should be clinically detected. Again, Total number should be 4. At least one should be a clinically detected node. So that is how you classify the nodes, because whenever you say clinically detected nodes, it means they are larger nodes, usually more than 1 centimeter. That is why it is grouped together like that. Right. Now going on to the markers for a melanoma, the IHC markers, which is the most specific marker and which is the most sensitive marker. The most sensitive marker which you have is your S100. This is a question that has come 2-3 times. So the S100 is the most sensitive marker as far as melanoma is concerned. The most specific marker is going to be MELAN A or MART1. The most specific marker is going to be your MELAN A or MART1. And HMB45 can differentiate the nevus from the melanoma. So the three markers which are commonly used are S100, MELAN A or MART1, and your HMB45. The most sensitive is S100. The most specific is your MELAN A or your MART1. And here, though it will appear that HMB45 can also distinguish, if you look at it, it is found to be better than HMB45. So the most sensitive is S100. The most specific is MELAN A. The name itself has it. MELAN A, melanus. I know it's melanoma. MELAN A is the most specific marker. HMB45 can be also sometimes used. The next thing is, how do you deal with the melanoma? As I already said, any melanoma, the treatment is going to be a wide excision. What is the margin of excision? Simply for a, basically for a thin melanoma. Okay, for a thin melanoma, for T1 melanomas, the depth is going to be, the width is going to be 1 centimeter. For anything which is more than a thin melanoma, the margin is going to be 2 centimeters. Now, there is one thing called as an in situ melanoma, which is mentioned, for which you can give a margin of 0.5 to 1 centimeters. Okay, so in general, we say whenever there is a thin melanoma, it's a 1 centimeter margin. For anything which is greater than a thin melanoma, which is greater than 1 millimeter, you have minimum give 2 centimeters. People have compared 2 centimeters versus 5 centimeters. They have compared 3 versus 5. Like that, they have compared 2 versus 3. There is no comparison. That is why they give the margins as 2 to 3. But in general, now classically, whenever we talk about melanomas, the maximum margin we need to give is only 2 centimeters. So 1 centimeter for thin, and when we talk about thick melanoma or intermediate or high thickness, then you go for a 2 centimeter margin. Okay. So here 1 to 2 is mentioned as 1 to 2, but just take it out. Just remember as 2 centimeters. Anything which is less than or equal to 1 millimeter is 1 centimeter. Beyond that, and if it is a melanoma in situ, it is going to be 0.5 centimeters. So if the dermoepidermal junction is not reached, then you call it as a confined to the epidermis. Then you call it as an in situ melanoma, where a 5 millimeter margin can be given. In general, mark it as minimum is a 1 centimeter margin you will not go wrong. And shave biopsies are usually done for SCC and BCC only. It is not advised in the diagnosis. Excision with 1 millimeter margins for small lesions, and punch biopsy up to 4 millimeter dip for the large lesions to the thickest part of the lesion. Now, the biopsy question has come multiple times. The excision margins have come multiple times. The HMB45 and S100 and the MELAN A have come multiple times. So all these, the slide is very important for that, for you to understand what is the extent of this one you have to remove. Okay, for extent you have to understand this particular slide. Just go through multiple times. It will give you a very clear answer. In general, thin melanoma 1 centimeter. Intermediate or thick melanomas are going to be 2 centimeters. So that is why it is mentioned as up to 2. You can take 1 to 2 centimeters. But in general, it is thin melanoma is 1 centimeter. Anything more than a thin melanoma, you go for a 2 centimeter margin as far as the melanomas are going to be concerned. Now, which are the indications for SLNB? All are indications except, so which is the only one where SLNB is not indicated. Okay, so the answer is only one. Okay, when you have basically a melanoma with a thickness T1A melanoma, in other words, you have a T1A lesion, that is the only one where you do not have an indication. So if you look at it, this is an acral melanoma, 0.7 millimeter in thickness, no mitosis. So the indications for doing a SLNB include all this, like greater than 1 millimeter thickness always. So T2 and above always needs an SLNB. Again, T1A, people say with ulcer. So T1B is basically with ulcer. No? So anything which is more than 0.7, 0.8 millimeters. So less than 0.8, no ulcer, no mitosis. You can remember these 3 criteria. The 3 criteria that you have is up to 0.8, less than 0.8 thickness, no ulcer, and no mitosis is present. So these can be observed without an SLNB, because the risk of node metastasis is less than 5%. As you already mentioned, desmoplastic, some people will prefer not doing because the risk of metastasis is again very low, but still it is not the standard of care. So as far as people are concerned, currently the only indications are melanomas up to 0.7 millimeters and no ulcer and no mitosis. Any mitosis which you see clearly makes it as eligible for a SLNB. So the management of a melanoma is the wide excision, right? Now, which is the most important prognostic factor for survival? Previously, the answer used to be thickness. Now the answer is node involvement, clearly given in both Bailey and its substance. Node spread is the most important prognostic factor for survival in melanomas. Breslow's thickness, again, thickness when you look at it, Breslow's thickness is what you look, not the Clark category. The Breslow's thickness is the most important factor in the absence of node metastasis. That is for a stage 1 melanoma. So any lesion needs a SLNB for more than 1 millimeter, which we already discussed. So SLNB was started by Morton et al. Using the technetium 99M sulfur colloid, blue dye you can use, and basically you raise a wheel 5 millimeter away, place it in the subdermal plane. You use 0.5 millicurie of sulfur colloid or dye, usually up to 1 to 2 ml will be used in that area. You raise a wedge, but within the margin of excision, you give the drug and you give a subdermal injection, not subdermal, you give a intradermal injection. And this is what was done in the melanoma sentinel lymphadenectomy trial. Okay, so melanoma sentinel lymphadenectomy, they can give you, this is the nodal architecture. You can see that this is the capsule of the node, and you can see the clearly cells which are deformed here. The melanoma cells can be seen going on to the capsule of the cells. This is your dynamic sentinel lymph node being done in the inguinal region. You can see the saphenous vein here, and you can see the blue stain dye in this particular region very clearly seen. Now remember, there are a few principles as far as melanomas are going to be concerned. You have to use, the presence of sentinel lymph node in the in-transit lesions which are going to be there. So a pre-op lymphoscintigraphy is mandatory. Pre-op lymphoscintigraphy becomes mandatory. Okay. Just a moment. Or there was a slide on some other extra features. Anyway, forget it. Now, when we talk about the axillary dissection, inguinal dissection, and cervical nodal dissection, the node dissection differs in melanomas. For an axilla, you always have to do till level 3 as far as the melanomas are concerned. So you have a melanoma in the arm or in the forearm or in the fingers. When you're doing an axillary dissection, you have to always do till level 3. Then inguinal nodes, when you're doing, you do the superficial nodes, pelvic nodal dissection, whenever there is a significant prophet nodes or a multiple inguinal nodes are present. Cervical, again, the minimum that you need to do is an MRND type 3, and here parotid nodes always need to be addressed. Okay, parotid also, that area, superficial parotidectomy, in fact, some of them recommend as a routine. So the neck dissection or any kind of node dissection in a melanoma is slightly different. One is when you are doing your SLNB, again, there is a difference. You always have to use a radio tracer. You always have to use a radio tracer, and you have to do a pre-op lymphoscintigraphy like this. Why? Because you can have these, other nodes which can be present. You can have what is known as your intercalary nodes. When you talk about the nodes in melanoma, you may have something called as the intercalary node. So scintigraphy becomes mandatory. Why? Because of the interval or the intercalary or intercalator nodes will be there. Like for example, you can get a popliteal node, which you can make out here. You can see that there is a popliteal node here, or it can be an epitrochlear node. Now, in many cases, 80 to 90% of cases, this may be the only positive nodes which you find. So if you give the injection and then you have the node in the popliteal or in the in the cubital fossa, normally we do only axillary dissection or inguinal dissection. So if you don't do the lymphoscintigraphy, you can miss these nodes, and these may be the only nodes which are present in those kind of patients. So again, in-transit lesions can also be present. So this lymphoscintigraphy is mandatory. Lymphoscintigraphy is mandatory. The second thing is whenever you're doing, you have to do till level 3 as far as the axilla is concerned, and cervical, the parotid nodes have to be addressed. Third thing is no frozen section. No frozen section. A proper assessment is needed. So frozen section is not done for lymph nodes in a melanoma. Melanoma always it is a permanent section, and then the node dissection, if it is needed, is done as a stage procedure. Of course, if you have a grossly positive node, gross positive node is there, then you can go for a node dissection. That is fine. But on the other hand, if it is only found on SLNB, you're not sure whether a node is positive or not, in such cases, you will not complete the nodal dissection. So 3 factors. One is always lymphoscintigraphy has to be done. because of the presence of the intercalary nodes or the intercalated nodes which will be present. So lymphoscintigraphy and so radio tracer is always something that is required. And then the extent of nodal dissection is going to be different in the various areas. And the third thing is no frozen section is done. It will be only a permanent section as far as the SLNB is concerned. So these are some things that we need to remember as far as the nodal dissection in a melanoma is going to be concerned. Now, when you measure the breath loss thickness, the measurement is from the top of the granular cell layer. Okay, so stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum. So the middle layer, the top of the middle layer, between the second and third layer, from there is where you take it till the deepest point of the melanoma. That is the measurement. It's not the basement membrane as it is seen in case of your squamous cell carcinoma of the oral cavity. Here it is from the top of the granular cell layer to the base of the melanoma, the deepest point of the melanoma you take. That is the nearest point on the you have to measure it and you have to take it. The single most important factor for survival is your nodal disease. And the most important prognostic factor in the absence, that is without nodal spread, is going to be your breast flow thickness as measured from the top of the granular cell layer. And as you already mentioned, satellite nodules are less than 2 centimeter and in transit are greater than 2 centimeter, usually in the direction of the lymphatic drainage. They can be present in other areas also. For example, this is a classical case. It's a truncal melanoma which is present near the umbilical area. So you don't know whether to do the right side, the left side, the axilla, which area to drain and do. When you do a lymphoscintigraphy, you can identify that there is a right inguinal node which is identified. The same way, when you are looking at it, you are finding the popliteal node here. You can see that the popliteal fossa is getting identified here. Okay, and similarly, when you have a submandibular lymph node and melanoma injection site is there, that one you are finding out. And here you are finding out an axillary node with an injection site. So, like this, various other areas can be found here. And anteroposteriorly, where it is found, all this lymphoscintigraphy has to be done for you in the management of central lymph nodes in the melanoma. Now, once you have done the wide excision plus either a nodal dissection or a sentinel lymph node biopsy as it is named. So, your node dissection can be done in clinically positive nodes. Clinically positive nodes, you will straight away go to node dissection. If it is a clinically node negative scenario, you do SLNB and then final histopathology, not frozen section. Okay, and finally, if there's node positive, at that time you'll go for a node dissection. So it will be a stage procedure that you will do here. Okay, so now you have done all that, you got a lesion. So what is going to be the management of such a patient? After that, what is going to be the management based on the histopathology? Now, in stage 3 disease, as I already said, the combination of BRAF and MEK inhibitors like dabrafenib, trametinib combination for 1 year. This is based on the COMBI-AD trial. Now, other than that, you also have adjuvant immunotherapy which can be given. So, the first agent which was used was ipilimumab. Okay, ipilimumab, which is an anti-CTLA4 antibody. Ipilimumab is an anti-CTLA4 antibody, which was the first immunotherapy agent to be used and approved, first used in melanomas only. So Egermont trial, this was the trial which was based on the Egermont et al. Trial. Now there is other agents which can be used are the nivolumab, which can be used based on the Checkmate trial. And then you have the pembrolizumab again based on the Egermont trial. So these are all anti-PD-1 agents. So you have an anti-CTLA4, which is going to be your ipilimumab. Okay, then you have your anti-PD-1. I have already told you this. These are all PD-1. There are only 2 PD-1 agents. One is your pembrolizumab. The other one is your nivolumab. Okay, pembro and nivolumab. All these 3 are the agents which are used in adjuvant therapy in stage 3 melanoma. Is there a role for adjuvant therapy? Yes, in high-risk patients based on the Trans-Tasmanian Radiation Oncology Group study. So this is a Australian New Zealand group which they do the study, highest incidence of melanoma. So they said that whenever you have any of the head and neck nodes, when you have a parotid node which is involved, then cervical and axillary 2 or more nodes which are involved, and 3 or more inguinal nodes. So 1 or more, any node in the parotid, 2 or more in the cervical and axillary, and inguinal is 3 or more nodes when it is present. So all these are high risk. And anyway, presence of extranodal extension, like in head and neck, every area extranodal extension is now taken into account. So extranodal extension, and the size when it is 3 centimeter for cervical nodes, more than 3 and more than 4 centimeters for the other size. So these are all indications for going in for adjuvant radiation. So 1 parotid, 2 or more cervical and axillary, and 3 or more inguinal regions, and size greater than 3 in the cervical region and greater than 4 in the other regions. Presence of extranodal extension, all of these are indications for adjuvant radiation as well. The first therapy which was used in melanomas as immunotherapy was actually interferon alpha to be later on, because it was very toxic. Then recent times we have had the resurgence in immunotherapy because they are found to be much more bearable. But even now, remember my friends, there are a few mortalities which are documented with immunotherapy. That is the flip side of immunotherapy, but still it is a very useful drug to be used. So when we talk about the management in advanced or metastatic, so when you have a BRAF mutant type, you use combination of dabrafenib or vemurafenib with trametinib or cobimetinib, and immunotherapy with CTLA4 and pembrolizumab or nivolumab, imatinib and sunitinib can be used in secret mutations, which is found in a certain proportion. In-transit lesions management. When you have extensive in-transit and satellite lesions, you can manage them. Usually, the preferred modality is an intralesional injection for small lesions. For small lesions, you prefer an intralesional injections. So here, there is a vaccine which is used, an oncolytic viral vaccine coded with GM-CSF, which is Dalimogene laherparepvec. Okay, so Dalimogene laherparepvec. So it's a herpes virus which is coded with GM-CSF. So that combination oncolytic virus is used, which is found to be very, very effective in the in-transit lesions. And remember, melanoma is one area where even if you have metastasis, if you can go for a resection, metastasectomy is the preferred option. In fact, in CNS, this will have one of the best prognosis. Overall, CNS is a bad prognosis, but among the CNS metastasis, if you take, the best prognosis will be there for a melanoma. If you resect a melanoma, that will generally have a good prognosis in the CNS metastasis. Overall, if you look at it in melanoma, CNS will have the worst prognosis. The worst prognosis is for the M1D, which is the CNS metastasis. Right. Now, there is another entity which can be used for the treatment of inside lesions and metastasis, that is known as your hyperthermic isolated limb perfusion. So hyperthermic isolated limb perfusion, what do? You isolate the artery and the vein, put a pneumatic tourniquet, and then you access the artery and the vein, and then you give it, and you give hot air blanket and raise the temperature there. Usually the agent which will be used is melphalan or it will be TNF-alpha. These are the drugs which will be used. So isolated limb infusion and perfusion. So in your isolated limb infusion, you do not use pump oxygenation. That is the difference between the two. It is a less restrictive thing. The tourniquet thing will not be very commonly used so much in your isolated limb infusion. So that is the difference between ILP and ILC. So I think we'll stop the class here today with this. All of you will have your Sundays to enjoy. Probably tomorrow I will just put up another this one. The last session we'll complete our non-melanoma skin cancer, BCC and SCC. Almost the whole class is now over. Only a small bit remains. So thank you, my friends. I hope this is clear. So remember, the management of melanomas is very significant, and it is something that will come again and again. Multiple times the questions have come. So melanoma is a high yield topic, and squamous cell carcinoma and SL and basal cell carcinoma also. It's a small topic, but it is a very, very important topic. That is why I've given some preference here to this. So all the best, and wishing you a happy new year again.